Good evening, everyone. Welcome to the BTOG ESMO in an hour, BTOG 2020 ESMO in an hour. I hope you're all ready to go and excited about the agenda we have for you. Three distinguished guests, as you can see. First of all, thank you to our sponsors. Without them, this would not be possible. So grateful to MSD and Pfizer for supporting us with this. And as ever, thanks to the universal presence of Dawn and Gina, who are the powerhouses behind BTOG and help us get these things organized. So next slide. There's a little bit of housekeeping before we kick off and you get to the main act, which is frankly more exciting than me rabbiting away. We're really keen this is interactive. So if you can, think of a question and send it to me. I have my phone next to me. Here it is. And if you type in your question into the control panel, it will appear as if by magic next to me, and I can interrogate our panelists on your behalf. And the feedback we've had so far is it's that Q&A which is really valuable. So please submit the questions. Just back up one if you could, Richard. I can't get back up one. There we go. Can we also send us your feedback? There is a certificate of attendance which you will get, but we're going to be mean and we're only going to give it to you if you send us the feedback. But it's really worth it because you get your CPD accredited RCP coded token. So please make sure that you do that. Right, so what have we got in order for you? We have divided ESMO into three broad areas. And ESMO essentially ran this weekend, and as you will know, it was a virtual meeting for various obvious reasons. The main body of the data, if you could go back up one, the main body of the data was on the weekend. And was yesterday, and we've divided it into three bits. We've got stage 3 disease, which is going to be kicked off by David Gilligan. We're then going to move on to the small cell lung cancer area, which Shobhit Baijal is going to go through, and we're going to finish with the TKIs and other targeted therapies with James Spicer. And we're going to have questions in each of those three bits afterwards, as you can see. So think of a question, and it'd be an honor and a pleasure to go through it with you. So without further ado, I will pass you on to David Gilligan. For those of you who don't know David, he's been a huge supporter of BTOG over the years. He's a clinical oncologist who's based at Addenbrooke's and at Papworth, and he's going to go through the stage 3 disease, which I think really is one of the highlights of not only the lung cancer program, but indeed the whole of ESMO. David, over to you. Thank you very much.
Thank you, Tom. It's a real pleasure to feed back to all of you from ESMO, and I hope I can share with you a few of the highlights that I thought were really important. I'm going to cover three main areas in 4 abstracts. The first one is the big ticket item, if you like, the long and keenly awaited results of the LungArt study by Cécile Lipichot. I'm going to mention a couple of neoadjuvant studies which were done of immunotherapy in resectable disease. And finally, just a quick update on the Pacific study. The menu is rather French, as you can see, but with also some very good comments from Rafael Dododuska. Been practicing that all day and haven't quite managed to get on top of it. Anyway, here we go. So the first abstract I want to talk to you about is the LungArt study, which was, as most of you will know, an international trial comparing post-operative radiotherapy or PORT to no PORT in patients with completely resected non-small cell lung cancer and mediastinal N2 disease involvement. And this arose from the PORT meta-analysis, which was published way back 22 years ago in The Lancet in 1988, but has been updated since by the MRC meta-analysis group. And what that showed was very, very clearly that stages of disease that were N0 or N1, there was no benefit at all. In fact, post-operative radiotherapy was actually detrimental and should not be used and has not been used since then. But in disease which was N2 positive, the jury was out with the sort of hazard ratio hovering around 1. And the important thing was that in these trials going back up to the 1960s, some of the radiotherapy used was positively Stone Age. So LungArt was designed and run by the French collaborative group, but with input from UK, Swiss, and other European groups. And basically, patients who had completely resected disease, so are not resection, with N2 involvement, and could have neoadjuvant or adjuvant chemotherapy, were randomized to either a control group or conformal radiotherapy, 54 Gray in usually 27 fractions. And you can see that the stratification factors are listed below. And the most important thing was that the primary endpoint was disease-free survival. And the hypothesis was that there would be a 42% disease-free survival in port versus a 30% in the control arm at 3 years. And the secondary endpoints are mentioned there, including overall survival. Here is a summary slide of some of the patient characteristics in the LungArt study. Nothing very surprising at the beginning. The median age, early 60s. The sex breakdown is what you might expect, as is the histology. And you can see that in both groups, which are well balanced, neoadjuvant or adjuvant chemotherapy was given in virtually all cases, 96%. One statistic which I thought was quite interesting was that around about 40% of patients had unforeseen or unpredicted N2 disease, which I thought was quite interesting, given that 90 to 92% of patients in the study had a PET CT scan. So I think this just shows the value that we now put on mediastinal staging with EBIS or EUS. Just over half the patients had more than one N2 disease positive, and the pneumonectomy rate was just around 10%. This is the key slide, and sadly, perhaps, the results were, this was a negative study. The 3-year disease-free survival in the control arm was 43%, and in port it was 47%, so it did not meet the primary endpoint, and the hazard ratio was 0.85. And this, not surprisingly, translates to no difference in overall survival. And you can see in the Kaplan-Meier curves that the overall survivals almost are superimposed. Interestingly, you can see that 3-year survivorship is in the 60 to 70% level, and also that 5-year survival is around and just over 50%. So actually, the good news to take from this is that these patients were actually surviving longer. They all had, by definition, stage 3 disease. So that's really a very positive outlook for patients with stage 3 disease. I'm going to talk a little bit about the patterns of relapse and the radiotherapy details. On the left at the top are some of the radiotherapy details of the treatment given, the heart dose and the lung dose, which I'm sure will be discussed. And looking at disease-free survival, you can see that in the control group, there was a high 46% rate of mediastinal relapse, and only 25% in the port group. But sadly, we can see that death as a first event in disease-free survival was much higher in the port group at 14.6%. And the table or the chart on the right was provided by Dr. Dadushka, who I think this summarizes it very well, in that port prevented progression and recurrence in about 19 patients, but port was possibly linked or responsible for the death in a number of patients due to cardiac or second primary cancers. So does this really mean that the future for adjuvant radiotherapy trials is over? And I think this will actually stimulate a lot of debate and about where we're going. You could say that if we know that the excess deaths were all due to cardiac toxicities, that by improving our radiotherapy planning, by specifically subdividing cardiac structures and making sure that we avoid certain cardiac structures, not just the whole heart, but sub parts of the heart, and using collaborative outlining with our radiologists and our surgeons and our pathologists to actually work out exactly where we need to target the radiation. This may be in the direction of travel. Also, 89% of the cases in the lung art study used 3D conformal. Only 11% were IMRT, and we are now using IMRT and VMAT solutions as part of that for many of our patients, and find that our dose distributions are much better. Obviously, protons and other radiotherapy developments are coming along, and they may be important as well in protecting normal tissues. However, we can't get over the fact that the recruitment rate was poor. This study was powered originally to recruit 700 patients, and in 2017 it was recalculated to 500 patients, and it took 11 years to recruit those 500 patients. And the other factor is that in the last decade or so, we have newer modalities, and there are newer modalities using new agents and immunotherapy, which may confound the doing further adjuvant trials. So I think the take-home message is that PORT, as it stands at the moment, is not a standard of care in R0 PN2 positive non-small cell lung cancer. But I think we should take the message that because there are up to 46% of mediastinal relapse in the control group, we should really closely follow these patients, because there may be many salvage modalities that we can offer them. I'm going to touch very briefly on neoadjuvant immunotherapy in stage 3 disease or operable disease, and two studies that were presented, the UNESCO and the PRISEMT study. They're in some ways similar, in some ways quite different. You can see that both were looking at early stage disease, and both gave single agent immunotherapy, the atezolizumab, just one cycle in the PRINCEPS trial, and 3 cycles of durvalumab in the other study. They also had high rates of R0 resection. What was really interesting, I think, was the correlation looking at pathological response or major pathological response, which is less than 10% of viable tumor remaining, and looking at those in more detail. The figures you can see, 17.5% and 14% respectively, are perhaps at the lower end of what we've seen in previous studies, but I think the definition of major pathological response has changed and refined and perhaps become more precise and improved. But interestingly, there was no correlation in both studies between radiographic, or in the PRINCEPS study, metabolic response. And they showed some really very clear slides of PET scans which were shining very bright and very hot after adjuvant immunotherapy, but when looked at histologically had a major pathological response. The difference was that the UNESCO study was stopped early because of a 9% 90-day mortality. And just looking at that maybe a little bit in more detail, you can see that the trial was stopped early. Interestingly, only 14% of patients had stage 3 disease, so that means 86 were stage 1 and 2. 3 patients progressed before surgery, and 20%, there's a 20% pneumonectomy rate, which seems to me to be very high, and I think this study needs to be looked at in more detail to see what are the issues around the surgical parts of the study. Whereas the PRISEMT study was perhaps more conventional, with a third of patients with stage 3 disease and a 7% pneumonectomy rate. And then finally, Corinne Favafin presented the PACIFIC study, the 4-year overall survival update. And you can see that separation of the curves is maintained. Median survival has just been reached. Median overall survival is 47.5 months, and the 4-year survival is 49.6%. And the benefits were seen through all subgroups. So that's some really good news at that study, which has changed our practice, and we are continuing in, that there is durable response out to 4 years from the update. So that concludes my tour of stage 3 disease and non-small cell at ESMO, and look forward to any questions. Thank you.
Thank you, David. You also win the prize for being within time, so you get a golden apple for that. Well done. We had lots of questions coming through, which is fantastic. First of all, I'd like to thank David for going through that. It's really quite onerous actually doing this. You essentially get an email from us about a month beforehand saying, would you mind presenting this data from ESMO? And then you have to spend all weekend going through the abstracts whilst the rest of us were off enjoying the last of the sun. So it's a lot to do, and we're very grateful for all of our panelists. I've got a question here from someone called Sanjay Popat. I'm not entirely sure who he is, but he's got a question for you, David. He's written down, lung art was a negative trial. Post lung art, are there any R0 resected N2 patients that should get post-operative radiotherapy? Or is this the end of radiotherapy for that group?
I think we have to, I mean, there are always exceptions, and you can always find very intricate reasons why you might want to, but I think broadly speaking, the answer is no. Clearly, if you have R1 disease or R2 disease, then you do need to consider treatment. And sometimes there are, certainly in the MDTs that I've been involved in, quite lively debates between the surgeons and the pathologist as to whether the resection that they've given the pathologist is R1 or R0 based on staple lines and things like that. So I think that will obviously continue, and I think there is clearly a case for radiotherapy in R1 disease where there is a microscopic positive margin, and that's always a challenge from a clinical oncology, radiation oncologist point of view, because you do need to sit down with your surgeon, your radiologist, and your pathologist to work out what the target volume is going to be. But to answer the question, broadly speaking, I'd say no, in R not N2 disease.
Thank you. And in fact, you read my mind, which is extremely impressive, because another question is really, you sort of answered, which is saying, would you recommend post-operative radiotherapy if there was extranodal spread and hence positive resection margin? I guess it's coming to a little bit what you were saying there, which is, what does the R1 mean? And extranodal spread, we've tended to be quite worried about that additionally, haven't we?
Yes, and I mean, I think it's important to note that in the lung art study, patients with extracapsular spread were excluded. And I remember, going back to the fact that lung art was quite a difficult study to recruit to. We were in Cambridge, a centre, but I think we struggled to find any patients to go into the study. And it was one of those studies where every patient we tried to recruit or put into the study somehow found themselves in an exclusion criteria. And I remember extracapsular spread was one of them. So I think for extracapsular spread, then there is a case.
We have a question from Corinne Favourafin, so mentioned in dispatches. First thing she said is lung art is not a negative study. It's a practice-changing study. I think that's absolutely right. That will help us inform our patients about optimal care. But her question is, overall survival in both arms of lung art is excellent and compared very favourably with that of the Pacific study. Does this mean the question of surgery versus concurrent chemoradiotherapy is still topical? Are we still going to go back to that familiar argument, David?
Well, firstly, to Corinne, I absolutely agree. I suppose the word negative has negative connotations, and it's not a. I agree that we should be talking in terms of practice changing. As I said, the results in both arms were exceptionally good, and I think that all I can say is that I think the debate will continue about the optimum management of stage 3 disease. Now, there clearly are cases where disease is inoperable and surgeons would not want to attempt a resection. There are cases where maybe, certainly single station N2 disease where, and no evidence of, say, mediastinal invasion, where surgery should be considered as perhaps the main modality, or certainly an equivalent modality in stage 3 disease. So I think there will still be the inoperable and operable, but there will also be a grey area in between where we will, in MDTs, enthusiastically debate. But most importantly, I think, and this sometimes comes out in our clinics, is that we have a discussion with patients about what they want and what they are prepared to accept. Because it's important to say that, you know, if someone has a resection, and by and large in the UK, we're giving adjuvant chemotherapy, that patients, not neoadjuvant, that patients will have to have a discussion about whether or not they're going to have adjuvant chemotherapy. And then we get into that debate about the small benefit in adjuvant chemotherapy. So I think all of those things have to be considered, and that in someone being operable, it does mean, yes, they may be operable, but then we're talking about combining post-operative chemotherapy with that as well.
And in fact, it chimes in with a question someone came through, which is very much about that, saying, you know, given the 5-year overall survival seen with lung art and no post-operative radiotherapy, how do you frame adjuvant chemotherapy in that setting? I think it's a really good point. You begin to wonder quite whether that benefit from chemotherapy is worth it. I've got another question coming through. We've got lots of these. This is very exciting. Thinking a little bit about the neoadjuvant studies you touched upon, the DERVA and the ATESO studies, they talk about an MPR, a major pathological response rate of somewhere between 14 and 17%. What would we expect to get with just standard chemo? Are we seeing a genuine immuno effect here? Or is this just an adjuvant therapy, and should we just be giving them chemo instead?
Yeah, well, it's a good question, and you're challenging my memory banks to remember for studies like that I've been involved in with LU22 what the pathological CR rate. From memory, I think it was certainly much lower, single-figure percentages. So I think there is probably something going on there.
Thank you very much. We've got a couple, just looking at my little clock to make sure we don't go over. No, we're looking very well. Question here from Mr. or Mrs. Anonymous. Should we consider post-operative CT scans to confirm complete N2 resection? How useful that's going to be? I mean, when someone has taken all the nodes out, do we expect to see an empty mediastinum, or would we still see some reactive nodes because you can't, in reality, get everything out despite your best intentions? I appreciate you're not a surgeon.
That's a really good question, and I think that's an area that we need to look at more and more, because the post-operative mediastinum, I think, is something which we all need to know a little bit more about, and I'd be very interested to have a discussion with the radiologists about what the benefits are, what modalities should we use. Given what we said about looking for mediastinal recurrence, I always feel that a baseline scan is a good thing to have. And the whole follow-up question in lung cancer is a very difficult one, but we should probably be stratifying it with various factors, including nodal disease. We've also seen some nodes come up, and we've biopsied them, and they've had surgical material in them, and they look big, but they're not pathological. So I think that imaging the CT scan, imaging probably by CT, because I think anything else practically in the UK as things stand at the moment would be difficult. But imaging by CT, we probably have to have better protocols in following patients up.
Thank you very much, David. So we're going to move on. I'm a little bit worried about my internet connection, so if I start freezing, many apologies. We're going to move on to Shobhit, and we're going to move on to small cell lung cancer. So Shobhit is medical oncologist up in sunny Birmingham. Small cell has traditionally been a little bit neglected in lung cancer presentations, but of course hit the highlights with chemoimmunotherapy around 2 years ago. And Shobhit's going to kindly update us on the new developments from this ESMO. Thank you, Shobhit.
Thank you, Tom, and welcome everybody. Thank you for tuning in. So I've been tasked with updating you on the small cell data. Without doing any spoiler alerts, it probably wasn't the most practice-changing of ESMOs for the small cell landscape, but still I think some important studies that probably help us understand the disease process better and probably give some idea of future directions. So I'm going to start off with limited stage and then move on to extensive stage. So the main headline, I'd say, from the limited stage study was presented by Solange Peters, and this was the Stimuli trial. This was looking at consolidation dual checkpoint inhibition with nivolumab and ipilimumab versus observation in patients with limited stage small cell lung cancer that had completed concurrent chemoradiotherapy. We look at the trial design, so eligibility, limited stage, good performance status, and adequate lung function. Patients were allowed 1 cycle of chemotherapy before trial enrollment, and then they moved on to concurrent chemoradiotherapy with either cis or carbo etoposide, completing 4 cycles with PCI to follow. Patients were stratified as to whether they had twice daily or once daily radiotherapy, and it was at this point that they were randomized to receive either the experimental arm with nivolumab, induction nivolumab, and I'd say an eye-watering dose of ipilimumab, 3 milligrams per kilogram, and then moving on to maintenance nivolumab versus observation, with the primary endpoint being progression-free survival. If we look at the patient disposition, I think this might give a heads up in terms of where the clinical outcomes heading for this trial. So the first thing to note is that even for a clinical trial where you've got pre-selected patients, there was a very high attrition rate for patients either not completing or progressing on the concurrent chemoradiotherapy. So although 222 patients were initially enrolled, 35% of these were not randomized. For those that were randomized, as you can see, in the experimental arm, only 8 patients completed their treatment. And in fact, there's about an 80% treatment failure rate. And this was mainly driven by drug toxicity. In terms of the observation arm, less than 50% of patients completed treatment visits, and expectedly this was driven mainly by disease progression. Based on that, I think it comes as no surprise that in terms of the primary endpoint for this study, this was a negative trial. Median PFS 10.7 months for the experimental arm compared to 14.5 months for observation, giving a hazard ratio of 1.02. Also worth noting that the median time to discontinuation in the experimental arm of treatment was 1.7 months. So really a tough regime for patients to tolerate. Again, and as expected, based on the PFS, the overall survival was not in favor of the experimental arm. But worth noting that the curve does cross at kind of the 2-year mark, giving a hint of some long-term, some patients that are getting some long-term benefit from IO exposure. Adverse events, so more than 50% grade 3 to 5 adverse events in the experimental arm. And again, a lot of these patients not able to continue treatment, which probably drove the clinical outcomes for this study. So Stimuli negative trial, mainly driven by treatment discontinuation. There are a subgroup of long-term survivors and clearly a better understanding of the biomarkers that's driving their benefit would be useful. Although a negative study, I think this is an area still of ongoing interest and ongoing studies. So hopefully in the near future, we will have something that mimics what we are achieving with the Pacific trial in the non-small cell cohort. So moving on to extensive stage. Now, the first thing I'm going to talk about is the EORTC 1417 trial reaction study. This was a phase 2 study. Sounds familiar based on what we know from IMPAL 133 and Caspian study looking at pembrolizumab in combination with platinum etoposide chemotherapy for patients with untreated extensive stage small cell lung cancer. If we look at the study design, there is a subtle twist in this trial. So patients had 2 cycles of induction chemotherapy to begin with, either cis or carbo plus etoposide, and only those patients that responded to treatment were then randomized within the study. So really pre-selecting chemo-sensitive patients to see if this could potentially drive a better clinical outcomes. Patients were randomized to receive then 4 cycles of either chemotherapy plus pembrolizumab, or followed by maintenance pembrolizumab, or chemotherapy 4 cycles alone. PCI was optional, but note there was a crossover option for patients. So those patients that did progress after 3 months of chemo exposure could then cross over to the experimental arm. And about 30% of patients in the study did cross over. In terms of adverse events, there was no real concerning safety signals. But if we go to the primary endpoint of progression-free survival, as you can see, unfortunately, again, this is a negative trial, median PFS of 4.7 months for the experimental arm, compared with 5.4 months for the standard of care arm. If we look at overall survival, this was actually positive with a hazard ratio of 0.73. Despite the p-value, this was based on the predefined statistical parameters. So theme of small cell, I'm afraid, another negative trial, this time a study looking at pre-selecting chemosensitive patients to see whether they would get an increased benefit from IO chemo exposure. Although there were no safety signals, the primary endpoint was sadly not met, although there was an improved overall survival despite the relatively high crossover rate. So in conclusion, what we can say is that chemosensitive small cell lung cancer behaves similarly independent of the addition of immunotherapy to chemotherapy. And the last two studies, which I've combined together because they really are looking at the same aspects. So these are studies that we're pretty familiar with. So Caspian and Empower 133. So these are the studies that really established chemo IO within the extensive stage small landscape. So just a quick reminder of both studies. So very similar designs if we exclude the Durva-Tremi arm in the Caspian study. So looking at either atezo carbotopside versus carbotopside in the Empower 133 study, and substituting the atezolizumab with Durva in the Caspian study. Some subtle differences in that Caspian was unblinded. There was a choice of cisplatin or carboplatin. PCI was excluded. Overall survival was the primary endpoint in both studies, and both studies were positive. But if we focus initially on the Caspian study, so we've got PFS and OS, both positive for this study. But if we dig a bit deeper in, what we can see is that the lines, the curves actually stay together until probably the chemotherapy component has completed. And it's that point in time that we see the divergence in the curves, giving a suggestion that there's some long-term benefits from immunotherapy exposure. So there's an exploratory analysis to look at two factors. One is biomarker analysis to see whether tissue TMB could correlate with outcomes for the long-term benefiters, and also clinical characteristics of these patients that are getting long-term benefit. And they define long-term benefit as anyone who had a PFS of greater than 12 months. And what we do know is that in terms of PFS greater than 12 months, patients who received IO plus chemo had an almost 3 times greater chance of being a long-term benefiter compared with chemotherapy alone. Looking at tissue TMB, looking at several different cutoffs. If we look at the forest plot from less than 8 to greater than 14 in terms of mutation megabases, what we see is that there was no correlation in terms of the hazard ratios for overall survival, regardless of the treatment arm based on TMB, really telling us that for this group or this population, tissue TMB is not serving as a useful biomarker. In terms of clinical characteristics, again, no real news headlines here. Understandably, patients with poorer prognostic features do less well. But it's interesting to see that there are patients with the poor prognostic factors that benefit from treatment with the chemo-IO combination. Moving on to the Empower 133. So we're seeing a very similar pattern in terms of the curves, that late divergence once the chemotherapy completes. And again, an exploratory analysis into what they define as the long-term survivors, i.e. patients who live more than 18 months from randomization. And if we look at patient characteristics and disease characteristics being the poor prognostic markers, what we can see is that patients derive greater benefit, or there's more long-term survivors for all parameters for those patients that had atezolizumab plus chemotherapy. But when we look again back at biomarkers, this time the group looked at blood TMB and PD-L1. there is no correlation with high TMB or PD-L1 positivity and chance of being a long-term survivor. So again, not serving as useful biomarkers. So in conclusion, as is well established, platinum etoposide plus IO provides meaningful survival benefit for our advanced small cell lung cancer patients. And we do have long-term survivors in these groups of patients. Patients seem to benefit regardless of patient or disease characteristics, but what we still are lacking is a useful predictive biomarker. So in terms of small cell in a nutshell, ESMO 2020, no real practice-changing data. Limited stage small cell remains a high unmet need, but other trials underway in this landscape. In terms of extensive stage small cell lung cancer, we do now have a standard of care with chemo IO with long-term survivors, but a better understanding of biomarkers that may identify patients that will derive the greater benefit would help in future algorithms. Thank you.
Thanks, Shobhit. That's brilliant. And you also to time, so you also get a golden apple. Well done. So we've got so many questions coming through. It's terribly exciting. One question I've got, which I can go for first because I'm holding the controller, is looking at that EORTC study described as a bit disappointing. That's the Pembro one, obviously. The median overall survival, I believe, 12.3 versus 10.4 months, described as a negative study. And yet, IMPAL 133, which made the presidential act at World Lung in Toronto 2018, median overall survival 12.3 versus 10.3 months. So the exact same thing. And yet one is seen as groundbreaking and one is seen as a bit of a disappointment. Is that just a fluke of design? Are we being, why are we less excited about this? Is it because it's a bit of a Me Too study?
Yeah, I think there's an element of trial design, and if we look at the keynote, I think it's 604, the Pembro chemo one, which was again only just negative, despite Caspian and IMPAL 133 being positive. I think there is an element of trial design, but I think also what we're seeing here, for me anyway, is that the key is we're not, and this comes out from the prognostic markers that we saw in the other two studies, is that the key thing is that there are patients who respond regardless of factors. So pre-selecting chemosensitivity doesn't seem to change the paradigm.
Absolutely. Thank you. We've got a question from Clive Pedal, and this kind of reflects my thought of your excellent description, Shobhit, of eye-watering doses of immunotherapy. And his question was, in Stimuli, is there a fundamental design flaw in that study? The discontinuation rate was really very high. I think he's got a really good point there. Do you think this should be done differently?
Yeah, I mean, I think that was an issue, and listening to the talks and discussions, I think it was really driven by the early Checkmate 032 study, where it seemed as though that dose was tolerable for the extensive stage population. But I think it is a learning curve. I mean, it's kind of melanoma doses. We don't touch our non-small cell lung cancer patients with it, and we instinctively feel our small cell population are a poorer group, and they're already having a tough treatment with the chemo rad, so then moving on to that. So as I said, I don't think this is a done deal for IO in the limited stage landscape. I think looking at drugs, looking at doses, looking at timing of bringing in the IO, I think these are all paradigms that will hopefully read out in the future. But yeah, I think that was, for me, and I'm sure everyone else feels the same in hindsight, I think that IPI dose was questionable.
It's interesting, isn't it? If anyone was part of those studies, I know quite a few people in the audience were, do let me know your experiences. Clive also asks, where does consolidation thoracic irradiation now fit with patients with extensive stage small cell getting chemo IO? Do you do that routinely with your IMPAL 133 regimen patients? Do you offer them thoracic radiotherapy if they've got bulky disease, or does that now put you off?
I mean, so within this study, I mean, obviously, based on the doses of the IPI, if we don't factor that, the pneumonitis rate was 9%, so quite high. Personally, I don't. I don't offer the thoracic. I haven't yet anyway. But I think without the data, without the safety data, which I think that's key, I would feel hesitant to do it. And, as I said, we've talked about the doses of the immunotherapy used here. So and potentially different doses may be more tolerable. But I think without that reassurance, I'd feel uncomfortable doing it.
Thank you. And last question before we move on is from Sanjay, which is, given that stimuli was negative, what do you think will happen in Adriatic? And just remind the audience, Adriatic is limited stage small cell with consolidation durva or durva tremelimumab. Any gazing into a crystal ball, what do you reckon, Shobhit? Are you excited about Adriatic, or is it going to be a little disappointing?
I guess it all, as I said, for me, I think the driver here is the dose. Well, personally, I think it is the dosing that was used, and it's rather than the concept. We've seen from Pacific, and we know that radiotherapy, it makes or stimulates the response to immunotherapy agents. So whether combination PD-L1, CTLA-4 is too much for our small cell population, I think we'll have to wait and see. But we will have the durva arm as well in that study too. So, yeah, I'm excited. I don't think it's a done deal yet.
Thank you. So I think we're going to move on. Just one last comment from someone who was from Sanjay, who was one of the co-authors on stimuli, saying when it was designed, we didn't know the optimal NIV-IPI schedule at the time, which kind of makes sense. And I think as we've gone along, we've worked out the relative toxicities of the two potential doses. Okay, so Shobhit, thank you very much. That was fantastic. Last and very much not least is Professor James Spicer. James is a professor of experimental cancer medicine at King's, and he's also a medical oncologist at Guy's and Tommy's. And he's going to round up the targeted therapies part of ESMO, and that really was one of the fortes. And James, thank you very much for contributing.
Thanks, Tom. That's a nice introduction. Richard, if you could just allow me to share my screen. So I'm going to talk about some targets, none of which are particularly exotic, although some of the therapies that I'll mention are relatively new. I suppose I take on board the distinction that Corinne drew our attention to, the distinction between a negative trial and perhaps a less pejorative word, an informative trial. Some of these trials were both informative and positive and potentially practice changing, at least in the future, and two of them were supported by contemporaneous publications in the New England Journal to reflect that impact. So we'll come to those. So the first, the four genes that I've highlighted in that first slide, I've just put in this very familiar pie chart to remind us all that between them, they account for not unadjacent to half of all non-squamous non-small cell lung cancer. So we're talking about, in aggregate, quite a lot of our patients here. I'm going to focus first of all on EGFR, and assuming no prior knowledge, I'll just rehearse some of what we've got very used to doing over, well, getting on for 2 decades now in the first line setting with the earlier generation drugs. We treat to progression, and then we go looking for a resistance mutation, and if we find it in tissue or blood, we have a relatively new drug to use in that context. And in the first phase 1 study of that trial, impressive efficacy was seen, and that was supported in the AURA3 randomized trial with impressive progression-free survival benefit and clear superiority toxicity-wise, and that has become a standard of care for us. If a drug works in the second line setting, then usually the next thing to do is to see whether it works in the first line setting, and that was the background behind FLAURA, you'll all recall, again with an impressive hazard ratio for progression-free survival, and an overall survival benefit as well, as we saw in the New England Journal publication for FLAURA earlier this year. And so, according to national guidelines, in many parts of the world, first-line osimertinib is a standard of care, and actually one of the positive dividends of COVID has been the NHS sort of SACT prioritization access, which gives us first-line osimertinib in the NHS at the moment. So that's, if you like, our current standard of care. One of the discussants at this ESMO over the weekend, Leisha Seacrest, used this very useful slide, I think, to rein in what's become rather a menagerie of EGFR inhibitor plus studies, which are, I find personally quite difficult to get my head around. Yet another of these was presented at this meeting, and that's the one on the bottom of my slide here. That's adding apatinib, one of the VEGF TKIs, to gefitinib. And the way this slide works is that the control arms for each study are in grey. A green VEGF targeting strategy is shown, and then yellow is a chemotherapy combination. So, and right at the top is FLORA, the osimertinib PFS outcomes. So for these studies, I think we can, in aggregate, discuss them in this way. PFS benefit is present in most of these studies, although quite small randomized trials in some cases. The toxicity of the combinations is always in excess of that of these single agent TKI, and in the absence of an overall survival benefit, which we only have for the FLORA study, first line single agent osimertinib clearly remains the standard of care in advanced EGFR driven cancers. So as I say, if a drug works in the second line setting, test it in the first line, and if it works there, what about adjuvant? So we've heard about some adjuvant studies in other settings already in this meeting. The ADJURA trial was added to at this ESMO. So to bring everyone up to speed with ADJURA, as if you weren't already, this was a very simple study design in stage, actually the recruitment was in stage 1B to 3A patients, although the primary outcome was an analysis in only stage 2 to 3A. That was just osimertinib or placebo added to whatever patients were getting anyway, adjuvant chemotherapy wise. And the PFS benefit was pretty stonking, particularly in the more advanced stage. And we have an overall survival benefit, which was presented earlier on this year with impressive hazard ratio, although admittedly still immature data. And that OS data is included in the this week's New England Journal publication, together with what was newly presented at this meeting, which was CNS disease recurrence in EGFR positive resected patients. And cutting to the chase for the result from this particular aspect of the ADJURA study, you can see here yellow for a placebo. There were more disease recurrence events, of course, in that arm. And in particular, the distinction between placebo and osimertinib was highlighted in the CNS site, with 10 times more events, admittedly very small numbers. And the small numbers because, again, this is quite an immature analysis. But here's the CNS disease-free survival, an impressive hazard ratio. And these data appear in the New England Journal as well. I think the take-home message is that, we may have to wait a little while for access in the NHS for this context, but for particularly the more advanced resected stages of EGFR-driven cancers, we need to be considering this drug. And so as a first step, we need to be ensuring that our MDTs are configured such that we can actually get an EGFR mutation status in resected patients, because of course that has been a test without an indication until now. Sticking with EGFR and segueing into HER2, if you're a phase 3 jockey, and this is feeling a bit esoteric now, small studies of newer drugs might be a good moment to check your emails, but keep an ear open, because I think we're going to be hearing more about some of these approaches for what already is a bit of an unmet need. We do periodically come across these patients with, for example, atypical EGFR mutations, the most common of which are in exon 20, and most of those are insertions. And the discussant here, if you want to come back and peruse this webcast at your leisure, you might want to pause here and look at her quite nice mechanistic explanation of why exon 20 mutations both activate the gene and render it rather inaccessible to the conventional EGFR inhibitors. And those conventional drugs are pretty useless in EGFR exon 20 insertions, as we found out to our cost in a number of series, and in some contexts trying these drugs where we can get access for these patients when we identify them. Very low response rates. But this drug, updated at this ESMO, may be a way forward and looks really pretty impressive from an activity perspective. Mobocertinib in exon 20 insertions, a reasonable handful of patients here with a response rate approaching 50%. And you can see on the right in the swimmers plot that actually a lot of these responses are quite sustained out beyond 20 plus months. So that's a drug to watch for the future in this indication. As I said, I was going to segue into HER2 mutations. Actually, those are almost all exon 20 insertions as well, so a very parallel story. And a lot of these drugs, which are already approved in some indications, are said to be pan-HER inhibitors. But as you can see, again, historical data from small studies here, not very active in this particular mutation subset. So Mark Sochinsky presented an update on this multi-cohort study. Starting on the left, he'd already presented at this ASCO, this year's ASCO, the activity of this drug in this EGFR exon 20 population. And it's a bit unimpressive, a measurable but modest response rate. Presentation this weekend was focusing on what they called cohort 2, which was HER2 exon 20 insertions. And it looks like we have a small molecule that may be associated with some sort of respectable level of activity here on the left in the waterfall plot. Toxicity, you can probably get a flavor from the numbers on the right, is a bit more of a concern though. A lot of dose reductions and interruptions for toxicity, and some really too much in the way of grade 3 toxicities, nasty ones as well, diarrhea and mucositis. So this drug may need some tinkering, in particular with its starting dose. One more for your collection if you like new drugs. HER2 exon 20 inhibitor, tarloxitinib, not very active in EGFR exon 20, looking promising in a tiny study of HER2 exon 20. Again, this may be something for you to return to at your leisure if you're interested. I couldn't really move on from this area without mentioning some ADCs, although there wasn't a whole lot of talk about these at this ESMO. So antibody drug conjugates. This is using an antibody to deliver a payload. Some of these are pretty familiar drugs in other contexts, like TDM1 and DXD, or trastuzumab deruxtecan, which I'm still learning to say, but I know the breast oncologists know quite well. So this Destiny Lung trial was presented at this year's ASCO and looked pretty impressive in patients, lung cancer patients with HER2 mutations. So I think we're going to have a way of targeting these patients before too long. If you're into phase 3 trials, now's the time to tune back in. I want to focus now on ALK, which again is a pretty familiar target, but we're continuing to add to our armamentarium of drugs which are active in this area. A quick survey of the drugs we're already more familiar with. A couple of drugs, crizotinib and ceritinib, where the pivotal trials were compared with standard of care chemotherapy in ALK-driven patients. And then the ALEX and ALTA-1 trials respectively tested alectinib and brigatinib versus what had by then become the standard of care crizotinib in this group. Very equivalent hazard ratios in both cases, around 0.5. And at this ESMO, we have yet another drug tested against the punch bag, which is now crizotinib, lorlatinib, which is a drug which was dually designed to hit some of the common resistance mutations and to penetrate the CNS. And actually, fully a quarter of patients included in this randomized trial had CNS disease at enrollment. And here's the primary outcome, PFS, a very nice hazard ratio, despite an active ALK inhibitor as a control arm. Response rates in excess of 70% for the experimental arm. PFS performance 9 months exactly as expected for crizotinib and not reached for lorlatinib. And in the brain, patients with brain metastases not only enjoy at least the same degree of benefit, they possibly benefit even more numerically than patients without brain mets. The tornado plot, we're learning to call these things, the way of expressing the toxicities, looks a bit weighted against lorlatinib, but if you focus in on the toxicities of lorlatinib, a lot of those are very treatable and really not symptomatic from the patient's point of view. Right at the top, particularly hyperlipidemia, we need to remember to look for that with this drug. And of course, it's eminently treatable, and cognitive effects pretty well managed with dose reduction. And this drug is not associated with nearly the same amount of diarrhea and fatigue and nausea that we see with CRIS. Patient-reported outcomes clearly superior for the newer drug. So what do we do with all this information and all these new drugs in ALK inhibition? Which is the first choice drug? Well, there are a number of factors to consider. Maybe the CNS disease present or absent is a factor. We don't really know whether the ALK translocation partner matters about choosing which drug. Long-term tolerability is key, and I've just alluded to that. Are we ever going to see a lorlatinib head-to-head with alectinib? That would answer a number of questions, wouldn't it? But may never happen. And there are other drugs beside lorlatinib which are active in the brain, some more than others, as I've illustrated here on the right. Tom, I'm aware that it's nearly your supper time, so I'm going to wind up 2 more slides. I think it's important to mention this target in lung cancer. KRAS, we're terribly familiar with it. It drives 1/4 of non-squamous lung cancers. Mostly it's the G12C mutation. And you may remember that this is a tough drug to drug because it's not a kinase. It's a GTP protein acting here on the left downstream of many growth factors. But this particular mutation, the cysteine residue shown in yellow, is a molecular target for covalent inhibition. And that's the way that this AMG 510, a new drug, first rolled out at ASCO 2019 to great fanfare. Now has a generic name, sotorasib. And this, my last data slide, is the updated waterfall plot that was presented at ESMO. And you can see it looks pretty impressive. This drug for sure is adding up to being quite safe. No DLTs, very few grade 3 toxicities, response rate of 32%, and actually quite deep responses even at some of the lower doses. So this is segueing straight into a phase 3 trial versus docetaxel, and there's another drug from Mirati, which is also in the phase 3 space, both first line as well as second line. And this drug had its moment in the sun this week as well in New England Journal. So I'll stop there. I hope I've left a few microseconds for questions, and haven't frightened you too much with exotic genes, but I think we've got some new ways of using old drugs, and we've potentially got some pretty impactful new drugs coming down the track.
James, thank you very much. We'll forgive you your transgression into my supper time. I'll make sure Mrs. Newsom-Davis forgives you. So I'm just going to borrow 2 or 3 more minutes of the audience's time. I'm sure they won't mind, because quite a few questions have come through. One question is about the CNS protection with osimertinib in the adjuvant setting, and obviously we know the value of CNS protection, but we're also in a situation where osimertinib adjuvantly does not have an overall survival benefit. It does have a disease-free survival benefit, but not an overall survival benefit. Do you think that the CNS protection is now enough for you to start dishing it out to EGFR mutated patients after surgery, or do you need more?
Well, I think we're beginning to see signs of early signs of OS benefit, and the CNS protection is an important part of progression-free survival. We've always bought into that as lung oncologists, haven't we? And a lot of drugs now in our disease, as well as others in solid tumor oncology, are approved on the back of PFS benefit. in lung cancer, we certainly know that progression radiologically equals progression symptomatically, and that's true par excellence in the brain. So I think you make the case as well as I could.
A couple of similar questions on the same theme. The idea being really, with the lorlatinib data, do we need another first-line out TKI? Would this be your first choice, lorlatinib, or would you be keeping it up your sleeve for the relapse setting, which, let's face it, is going to be more of a challenge for us going forwards?
Well, it's always an issue in an expanding class of drugs, isn't it? Do you go with what you think is the most potent drug early, or do you keep it in the drawer for later? I think as a rule of thumb, it's often advisable to use the best treatment you have first. That very obviously begs the question, well, which is the best drug? And I think I very carefully hedge my bets on that score during my presentation. And to an extent, there are horses for courses. If you've got we know in ALK-driven disease, brain metastases are very common, and if they're not present at presentation, they're soon going to be. So I think we have to pay attention very much to the drugs which are more penetrant of the CNS. And I think my prediction is that with time, those drugs will be used more, and others that are less active in that part of the anatomy are less penetrant, both into the market and into the brain.
Thank you. Got a question from Joe Evans. Question and statement. Is the diarrhea aspect of exon 20, EGFR, and HER2/3 TKIs surmountable with budesonide or similar? And the reason she says that is she's thinking of the parallels with neratinib in breast cancer, similar grade 3 diarrhea without curb-minister steroids. Do you know anything about that, James? Do you know if steroids are helpful in that class of drugs? Because certainly the mucocutaneous side effects are quite problematic, aren't they?
Yeah, I'm pretty certain that there isn't any data on that yet. I mean, these are still quite early, non-randomized case series of drugs which are new in the clinic. I guess as a phase 1 trialist, I'm as guilty as most. Quite often we're rather paradoxically reluctant to wade in with a whole lot of primary prophylaxis for something that we think is going to be a significant toxicity, because we just want to describe what that toxicity is first of all. I hope that doesn't sound too callous. Certainly not. That's not our intention. But you understand, what I'm saying about the evolution of a drug. First of all, we have to know our enemy and describe carefully the toxicity profile, and then we see what we can do to mitigate it. But that learning from another environment is an obvious shortcut.
Brilliant. James, thank you very much. I think we will wrap up there. I'm just going to say 2 more things. One of which is one person has said it's worth mentioning that first-line osimertinib is now here to stay. That's absolutely true. It's now NICE approved. So if that tickles your fancy, then first-line Aussie is here. And Corinne mentioned at the beginning, which I forgot to say, which is that the Pioneer study, it's about the stage 3 patients, is comparing non-surgical to surgical approach of stage 3 disease, and is due to start recruiting in the UK next month. So with that all done, I'm going to thank my 3 excellent speakers. Thank you so much for taking the time to prepare all this at very short notice. It's fantastic. I'd like to thank the usual BTOG stalwarts, Dawn and Gina, and our IT colleagues back of house for organising this. I'd like to thank you, the audience, for being part of it. Please fill out your evaluation forms, otherwise you won't get any prizes or indeed CPD points. There are other webinars coming up on a sort of monthly basis. They've proved to be extremely popular, so keep your eye out for the emails, pass them on to your friends, and have a lovely evening. Good night.